So very good evening to all of you and welcome in this class. This is today we are starting our head neck series. CNS series we have also already completed in our 6 lectures. From today onward we will start head neck series and it will be completed in 7 lectures. So for this session to moderate, I would like to invite Dr. Anu Tiwari. She is the Senior Consultant, Royal Cancer Hospital Research Center, Kanpur. Dr. Anu, over to you.
Thank you, Dr. Surbi. I think this session is taken by Dr. Cessal. He is additional professor and head and neck clinical oncology at Regional Cancer Center, Trivandrum. Over to Dr. Cessal.
Thank you, Professor Shaleen Kumar, Surabhi Madam, Dr. Anu Tiwari, Dr. Rishi Agarwal. And I sincerely thank the AROI UP chapter for the kind invitation. I am privileged and honored to present this topic. So today I will be discussing mainly the radiological anatomy of the base of skull, nasopharynx, oropharynx, oral cavity, larynx, and hypopharynx. So I will take 40 to 50 minutes for my presentation. First, we will start the foramen of the middle cranial fossa. So you have the foramina in the middle cranial fossa and also in the posterior cranial fossa. So if you take the foramina in the middle cranial fossa, because this is a level which from the down we will discuss about the head and neck. So above, you have already discussed the brain. Now you are discussing below this, below the base of skull. So at the level of the base of skull, the foramina, so this you can see this is the optic canal. The optic canal transmits. This is optic canal, which transmits the optic nerve and the ophthalmic artery. Then you have the superior orbital fissure. Yeah? The superior orbital fissure is transmitting the 3, 4, 6 cranial nerves and also the first division of the 5th cranial nerve, that is the ophthalmic nerve. So this is a superior orbital fissure. So this is the area which covers the cavernous sinus. So you have this is a groove for the internal carotid artery. So you have the groove for the internal carotid artery. So this is the carotid canal. So from there, carotid canal, this is the internal carotid artery. Then this part is called the cavernous part of the internal carotid artery. So this is the area where I will show you a picture where the cavernous sinus involvement occurs either from the carcinoma of the nasopharynx or from the paranasal sinuses. You can see that. Then posterior to that, you have the foramen rotundum. So first division of the 5th cranial nerves is entering into extracranially. That is it's the head and neck region is through the superior orbital fissure. Then the foramen rotundum. The foramen rotundum is posterior and posterior. That is the foramen rotundum. Then posterolaterally, it is more posteriorly, you have the foramen ovale. So if you have the superior orbital fissure, the foramen rotundum and the foramen ovale, the foramen ovale is more posterior and lateral. And behind the posterior, this is the foramen ovale. The foramen ovale transmits the 3rd division of the 5th cranial nerve, that is the mandibular nerve. And posterior to that, then you have the foramen spinosum. So this is the foramen spinosum, which mainly transmits the medial meningeal artery. This is the medial meningeal. So it transmits the medial meningeal artery. Then you have this is the posterior clinoid process. You have the clivus here. Then you have the foramen lacerum here. So this is the weakest part of the base of skull. So this is below that you have the sphenoid sinus. So when there is this tumor from the carcinoma nasopharynx can enter into the foramen lacerum, then it can grow anteriorly and then it can lead the cavernous sinus. Okay, this is how the spread, and also you can have different mechanism by which you can have access to the foramen rotundum through the superior Pterygopalata fossa and also down foramen ovale. Then if you look into how you read a normal CT scan of the base of skull. So this is this is a bone window. So the soft tissue will be not clear. This is a globe. You have seen that. Then you have the superior orbital fissure here. Then this is a sphenoid sinus. Okay, this is a clivus. This is a petrosuffix. So the structures here are, this is the foramen ovale. This is the foramen ovale here. The foramen ovale is posterior to that. You have the foramen spinosum. So this is foramen spinosum on this side. Then you have the other foraminas. This is the foramen rotundum. I will show you later. This is the foramen lacerum. This is a foramen lacerum. And this is a carotid canal. This is a carotid canal on this side. And the foramen lacerum is connected to the jugular foramen by petrooccipital fissure. So this is the foramen of the jugular. This is the jugular foramen. This is the jugular foramen. This is the carotid canal. This is the foramen lacerum. You have the foramen spinosum here, foramen ovale. So the structure which I have not shown is the foramen rotundum that I will show you. So coming to the foramen rotundum, this is the pterygopalatine fossa. Pterygopalatine fossa is a crossroad, as it's a junction where you transmit many structures from oral cavity. From there, it can go to nasal cavity, it can go to the infratemporal fossa, it can go into the orbit, then into the brain. So, and also the connections. There are 3 posterior connections for the pterygopalatine fossa. One is the foramen rotundum. So this is the foramen rotundum. So this transmits, suppose if you have a lesion there in the pterygopalatine fossa, mainly either from the nasopharynx or from the nasal cavity, oral cavity, this is a junction there. So from there, from the pterygopalatine fossa, this can spread intracranially through the foramen rotundum, that is the perineural spread. This is the perineural spread from the pterygopalatine fossa to the middle cranial fossa through the foramen rotundum. There are 3 posterior connections. One is the foramen rotundum for the pterygopalatine fossa. So how will you identify the pterygopalatine fossa? This is the maxilla. This is the maxilla. Okay. So you take the posterior border of the maxilla. This is the anterior border of the pterygoid bone. So this is the pterygoid bone. So between the maxilla and the pterygoid bone, then you have a fossa here. This is the pterygopalatine fossa. The second posterior connection of the pterygopalatine fossa is the Vidian canal. So this is the Vidian canal. This is also called this is the Vidian canal. Okay. So this is pterygoid canal. This from here it goes to the Vidian canal, and this pterygopalatine fossa connects to the foramen lacerum through the Vidian canal. So this is the carotid canal. This is the foramen lacerum. So this is the superior most part of the foramen lacerum. This is the Vidian canal on the opposite side. And so now you have this is the internal acoustic meatus. You have the cochlea here. So this is the internal acoustic meatus. You have the cochlea here. Now coming to the connections. So I have already mentioned this is the pterygopalatine fossa here. The pterygopalatine fossa is connecting to the nasal cavity through a foramen called sphenopalatine foramen. This you will not be able to make out all. Okay. Then laterally, the pterygopalatine fossa is connecting the infratemporal fossa. This is the infratemporal fossa. I will take up the infratemporal fossa later. Infratemporal fossa is lateral to the lateral pterygoid plate, and also medially it is bounded by the zygoma, posteriorly the mastoid process, anteriorly the posterior wall of the maxilla. So this area is the infratemporal fossa. And the pterygopalatine fossa communicates with the infratemporal fossa through a pterygomaxillary fissure. So this is the pterygomaxillary fissure. Then it can communicate to the orbit through the inferior orbital fissure. So this is the inferior orbital fissure. Then it communicates with the foramen lacerum. This is the foramen lacerum. This is a triangular area, the foramen lacerum through the Vidian canal. And you have a small area, small canal. It may not be seen in CT scan always, this blue one. This is connecting the nasopharynx and pterygopalatine fossa. So from carcinoma nasopharynx, the tumors entering in the pterygopalatine fossa through this canal called the palatovaginal canal. This is the blue one. This is the palatovaginal canal. This may not be seen in always. So again, I am showing you this is the foramen ovale. This is the foramen ovale, and this is the foramen spinosa. But this is the mandible. So this is a mandibular fossa that is giving rise to the temporomandibular joint. You have this is a clivus. You have this is the carotid. Okay. So I'm sure you have familiar with all the foraminas and fossa, and this is called the buccal scaphe. So Meckel scaphe. This is the Meckel scaphe. So the Meckel scaphe contains the semilunar shaped Gesserian ganglion of the trigeminal nerve. This is the medialmost part of the middle cranial fossa is the Meckel scaphe, and this contains the trigeminal nerve. Now, when you take a cross section at the level of the pituitary fossa, you take a cross section at the level of the pituitary fossa, Then I have shown you a groove for the internal carotid artery. So this is the internal carotid artery there. This is the cavernous sinus. Okay. And cavernous sinus, the superior orbital, superior ophthalmic vein drains into the cavernous sinus. So this on this side, then you have the nerves here. And when a cavernous sinus is involved, so this is the area you come out. This is the internal carotid artery. You see in a CT scan, you see an MRI like this. This is the area you look for the cavernous sinus. This is the area you look for the cavernous sinus. In that, then this area enters into the superior orbital fissure. And the 3, 4, 6, these are the small nerves, 3, 4, 6 cranial nerves. And the first division of the 5th cranial nerve, ophthalmic nerve, that enters into the superior orbital fissure. And when you have a cavernous sinus involvement, mostly the third division of the 5th cranial nerve, this is the foramen ovale, which transmits the mandibular division of the 5th cranial nerve, that is usually spared. The 3, 4, 6, first and second division of the 5th cranial nerve is involved generally in the cavernous sinus involvement. So coming to the, so this I have already shown you. This is the semi-lunar shaped Gazerian ganglion. And so you have the pre-ganglionic and the post-ganglionic, the 5th cranial nerve. The post-ganglionic is after the ganglion divides into the 3 divisions. This is the ophthalmic, and this enters to the superior orbital fissure. This is the foramen rotundum, and this enters this enters to the foramen ovale. Okay, so coming to the connections again. One more. This is Pterygopalatine fossa. Again, I will show you. This is again a revision. So from the Pterygopalatine fossa, it enters to the medial cranial fossa through the foramen rotundum. And this again, the Pterygopalatine fossa is connected to foramen lacerum through the Pterygoid canal. This is also called the Vidian canal. So this is the Vidian canal on the opposite side. It enters into the foramen lacerum here, and you have the carotid canal. Then you have the jugular foramen, and the foramen lacerum is connected to the jugular foramen through the petro-occipital fissure. This is the foramen lacerum here, the jugular foramen here, and this is called the petro-occipital fissure. And there is a connection with the jugular foramen through the hypoglossal canal also. Okay, so this we have done the Pterygopalatine fossa, and then you have done the base of skull. We have clearly know what is cavernous sinus, what are the structures in the cavernous sinus, and the connections of the Pterygopalatine fossa. You have 3 connections posteriorly that I have already mentioned to you. Then anteriorly, I have mentioned the inferior orbital fissure. You can enter into the orbital fissure through the orbit. Then pterygomaxillary fissure, which connects the Pterygopalatine fossa to the infratemporal fossa. Then you have the inferiorly, you have the greater palatine canal. So that I will discuss when I discuss the hard palate. I will discuss how the Pterygopalatine fossa is connected to the oral cavity. Now coming to the foramen of the posterior cranial fossa, then you have the internal acoustic meatus. So you know that this transmits the 7th and 8th cranial nerve. That's the facial nerve and the vestibular cornea. The jugular foramen. So this is the jugular foramen. The jugular foramen I will take you. I have already shown that, but I will take that in detail because it has 2 compartments. Then it has a nervous compartment and also a vascular compartment. So this is a jugular foramen which transmits the 9th, 10th, 11th cranial nerve and also the jugular internal jugular. Now coming to the jugular foramen. So I have already told you that there is a foramen lacerum is there. It is connected to the jugular foramen through a petro-occipital fissure. So this is the area. Then you have 2 components are there. This is called the pars nervosa. Pars nervosa is more anterior and more medial, and pars vascularis, this is more posterior and more large. This is more posterior and more lateral. It's more big compared to the pars nervosa, which is more anterior and medial. Okay, in the pars vascularis, in the posterior compartment, you have the 10th, 11th, and cranial nerves and also the jugular vein. And in the anterior compartment, you have the 9th cranial nerve, that is the closure. So coming to the how you read an MRI scan of the base of skull. So we have seen the CT scan, then we have the base of the MRI scan. So I am taking only a few slices of MRI, one in the base of skull, other in nasopharynx and oropharynx and tongue. These are only sites I have taken the MRI scan. or all are normal MRI scans. So you have the 5 bones you have to understand when you look in the MRI, because we are using more for carcinoma and nasopharynx because that is the investigation of choice. That's how. That's why I put this. This is the pterygoid place. Okay, this is the clivus. This is a Pterygoid bone. So these are the 5 bones you have to look in the basic skull MRI. And if any of them are missing, so this is a clivus, this is a Pterygoid, this is a pterygoid. Okay, so then why you need to know this? Because this is an important thing. So if you want to know a nasopharyngeal carcinoma, to know extending into the this is the nasal cavity, then you need to know this is the nasal cavity. Then you need to know that this is anterior to the pterygoid bone. If any lesion extending anterior, I have the pictures with me, not for this class, because this pterygoid bone, which is anterior, then you have to understand that this is the nasal bone, nasal cavity. But it does not change the staging, but you need to understand. Now, so far we have discussed the base of skull. Now I am coming to the second part, that is the nasopharynx. So this is a fossa. This is called the lateral pharyngeal recess. Okay, I need your attention. This is a lateral pharyngeal recess. So this is the torus tubaris. This is the torus tubaris. This is the opening of the eustachian tube. And you have the longest cap. This is a prevertebral muscles. This is a pharyngeal mucosa. So this is a pharyngeal mucosa. This is the tumors arising from the pharyngeal mucosa. Then you have the longest capitis muscle. It's the longest collar muscle. And you have the muscles here in the lateral wall of the nasopharynx, because this can, the tumors from here spread to these muscles, and also from oropharynx, the lesion can extending into the nasopharynx. Okay, there is a comment that my slides are not moving. Is it right? Or okay. Okay.
I think it's moving. You are still on this slide only.
Okay. Okay. Yes. Thank you. Okay. So this is a muscle. There is a muscle called, this is the levator vale palatis. And lateral to the levator vale palatis muscle, there is another muscle called tensor vale palatis. And these muscles are arising from this. This is the levator vale palatis muscle, which arises from the Pterygoid and also from the medial part of the auditory tube, and also from the carotid sheath. There are 3 origins for this levator vale palatis muscle, and this is inserted into the palatal aponeurosis that I will show you when we discuss the soft palate. The tensor vale palatis muscle is a muscle which arises from the scaphoid fossa in the medial pterygoid plate. This is a medial pterygoid plate, and this is the lateral pterygoid plate. The medial pterygoid plate, there is a fossa called scaphoid fossa. The tensor vale palatis muscle arises from the scaphoid fossa of the tensor vale palatis muscle, and also from the and this hooks around the pterygoid hamulus. That's a lowermost part of the medial pterygoid plate, and it is inserted into the palatal aponeurosis. And I will show that. And this muscle is the medial pterygoid muscle, and all the muscles of the soft palate, all these muscles are innervated by the vagus nerve to the pharyngeal plexus. But this muscle, the tensor vale palatis muscle, is supplied by the medial pterygoid nerve to the medial pterygoid, which is the division of the mandibular nerve. This is a medial pterygoid muscle. This is the lateral pterygoid muscle. The medial pterygoid muscle is arising. This we need to understand because this comes in different path in the nasopharynx and also in the masticator space when we discuss, and also in oropharyngeal carcinoma. So the medial pterygoid muscle arises from the lateral pterygoid plate, the medial surface of the lateral pterygoid plate. And medial pterygoid muscle is not arising from medial pterygoid plate. It is arising from the medial surface of the lateral pterygoid plate. This is the lateral pterygoid plate, and it is inserted into the medial surface of the ramus of the mandible at the level of the angle of the mandible. That I will show you again later. This is the lateral pterygoid muscle, which is arising from the lateral surface of the lateral pterygoid plate. And this is the lateral pterygoid muscle. This is a parapharyngeal space. So if we have a tumor here in nasopharyngeal mucosals, nasopharyngeal recess, that's a fossa number. This can spread here to parapharyngeal space. This can spread to prevertebral muscles. It can involve the nasal cavity. It involve the ear. So it can go down into the oropharynx. It can go posteriorly into it can involve, this is the clivus, this is the sphenoid, the base is sphenoid. So this is how the nasopharynx, the boundaries. So the roof is formed by the the base is sphenoid, the posteriorly the base is occiput, it is inferiorly continuing as the oropharynx, and there is a defect, and anteriorly it is the soft palate, posteriorly there is a defect, anteriorly it is communicating with the nasal cavity. Yes, coming to the, this is the nasopharynx, so the normal anatomy. Now we are taking the CT scan. Okay, so how you will identify the muscles in the CT scan? This is the maxilla, this is a nasal cavity, this is a bone there, this is the pterygoid plate. Okay, this is the medial pterygoid plate, this is the lateral pterygoid plate. Okay, so you have the muscle arising from the, this is the levator vale palatal muscle, this is a tensor vale palatal muscle, and also you have the medial pterygoid muscle is little lower down. Okay, this is the lateral pterygoid muscle. Lateral pterygoid muscle is arising from the lateral surface of the pterygoid plate, is inserted into the condylar process, in the medial aspect in the condylar process of the body. And this is the coronoid process. This is the insertion of the temporalis muscle. This is the temporalis muscle. It is inserted into the superior and the medial surface of the coronoid process. So this is the, you can see the mandible continuous. This is the coronoid. It means it is below the notch. Here you are discontinuous. It is not continuous. It means it is a supernodus. It is due to the tilt. It is again. It is one cut down. You can see that you can see more of a medial pterygoid here, and you can see that this is the area. I want to show you what is it. What is an infratemporal fossa like? The infratemporal fossa is behind the maxilla. This is a mastoid. You have the mastoid here. And this is medially, laterally it is the zygoma or the mandible down. This is a mandible there. And superiorly it is the zygoma. So this space. And this is the lateral pterygoid plate. This is the infratemporal fossa. Okay, so I will again come across, this is a pharyngeal mucosal space. Okay, so if the tumor is confined to the pharyngeal mucosal space, it is tumor, the nasopharynx. Then this is a parapharyngeal space. This is the prevertebral space. You have the carotid sheath here. This is a masticator space. Masticator space involves the medial pterygoid, lateral pterygoid muscle, the masseter muscle, and also the temporalis muscle, and also the fifth cranial. So fifth cranial nerve is usually seen below at the level between the head of the medial pterygoid and lateral pterygoid. If it is slightly up, it is between the tensor vale palatal muscle and the lateral pterygoid. Then it is entering superiorly to the foramen. Inferiorly, so all at this level, infra level, just the infratemporal fossa, it is divided into the anterior and posterior division. The posterior division contains two nerves, that is the inferior alveolar nerve and lingual nerve. It's more or less having the same, and it is entering into the oral cavity. And you have the parotid space here. This is parotid space. Okay, the mastoid cells. Yeah, and this is the you have the, this is the carotid sheath here. Okay, this is the styloid process. So this is the parotid gland. So when you contour the parotid gland, you have to take up to the styloid process. So this is if you contour the parotid gland. Okay, so you have to take up to the styloid process and also go beyond that. So this is the matter. This is the parotid gland. Okay. Then okay, so I think this is a prevertebral. It is very difficult to make out the prevertebral muscles in a CT scan, but I will show you in a moment. Okay, so this is the pharyngeal mucosal space here. This is a prevertebral muscles. It can be very clearly made out in an MRI. Levator vale palatal muscle here. This is the tensor vale palatal muscle. And pterygoid muscles. This is the insertion of the temporalis. This is a masseter muscle. This is the mandible. Okay, starting up. And the sagittal view, you have the sphenoid sinus here. This is the clivus. This is the nasopharynx. This is the basis sphenoid, base occiput. You can see that this is the nasopharynx. Then you have the soft palate here. Okay, continuing anteriorly as nasal cavity. Coronally, this is also very helpful, and it is very important to know whether, suppose this is at the level of the foramen veil. This is a cavernous sinus. If you have any tumor here at extremity, this is what we have discussed earlier. And this is a pharyngeal mucosal space. Okay, this is a pharyngeal mucosa of the nasopharynx. This is oropharynx. This is at the soft palate here. This is the tonsil. Okay, so this is the pharyngeal mucosa space here. This is the green one. Okay, then you have this is the pharyngeal, this is the parapharyngeal space. Okay, and you have the lateral pterygoid muscle here. This is the medial pterygoid muscle. Lateral pterygoid muscle is inserted to the condylar process, and the medial pterygoid is inserted in the inner aspect of the mandible, the ramus at the level of the angle of the mandible. And you have this is the submandible. This is the submandible. This is the mesentery here, the mandible. And this is temporalis getting inserted. Temporalis getting inserted into the coronal process. So this is, I will explain one step ahead. That is this is the pterygoid plates here, lateral pterygoid plate. And from the lateral surface of the lateral pterygoid plate, the lateral pterygoid muscle is arising. And it is inserted into, this is the inserted into the pterygoid fovea. That is at the level of the condylar process of and it has two heads. That is, you have the two heads here. That is, one head is at the level of this is the upper head of the lateral pterygoid muscle. This is the lower head. The upper head is originating, have a different origin. It is originating from the infratemporal. This is the temporal surface. This is the infratemporal surface of the greater ring of the spinal cord. And this is the upper head, and the lower head is the more bulky one. This is originating from the lateral surface of the lateral pterygoid plate, and both are inserted in the condylar process. And the medial pterygoid muscle also have a superficial head. Superficial head is arising from the maxillary tuberosity, and the medial head is arising from the medial surface of the lateral pterygoid plate, and it is downwards, and it comes downwards, and it is inserted into the inner aspect of the muscle. Okay, this is a medial pterygoid, lateral pterygoid muscle. When you have a CT scan, the lateral pterygoid is more or less having a horizontal path. Okay, the medial pterygoid is downwards and lateral. And in oral cavity, you need to understand that in certain tumors can be supranotch disease. This is the notch. This is a notch of the mandible. And this is the condylar process. And the lateral pterygoid muscle is inserted somewhere here. The temporalis is inserted in the medial aspect and also the superior surface of the coronoid process. And this is inserted here. And if you can make out the coronoid and the condylar process in a CT, it means it is you cannot make out. It means you are dealing with a supranotch disease. It means it is a supranotch disease. If it is from an oral cavity, then it means it is an inoperable disease. And this is the structures which I have already discussed with you. This is the infratemporal fossa behind the maxilla and lateral to the lateral pterygoid plate. This is medial to the zygomatic arch, posteriorly up to the mastoid. There is different. If you look into the Gray's Anatomy and if you look into the other anatomy textbooks, the posterior aspect is slightly different. There are certain things, certain textbooks mention it as carotid sheath, certain mention as mastoid. Medially, it is lateral to the lateral pterygoid. Okay, so this is how you see in a CT scan. So this is somewhere. This is the infratemporal fossa. Right. If a tumor is involving a high infratemporal fossa, then that is not good. Then again, this is a repetition of what we have discussed so far because we are moving from the nasopharynx. So this is a pterygopalatal fossa. You have this is mainly for those who have joined late. Pterygopalatal fossa. You have the Vidian canal here. Then you have the foramen lacerum. This is a carotid canal here. Jugular foramen. Then you have the foramen ovale here. Foramen rotundum. Sorry, foramen ovale, foramen spinosa. Okay, there is no foramen rotundum. Yeah? This is a Vidian canal. Now coming to the oropharynx. So I have done with the nasopharynx as well as the base of skull. Now coming to the oropharynx. So anything behind the anterior two-thirds of the tongue and behind the hard palate, it is oropharynx. Superiorly, it is extending from the soft palate, and lower down up to the level of the pharyngeal. That is the superior and inferior limit of the oropharynx. So you have the hard palate here, you have the soft palate here. Then from the soft palate, there is a anterior tonsillar pillar, which is connecting the base of base of tongue with the soft palate. This is anterior tonsillar pillar, which is nothing but the palatoglossal muscle. So palatoglossal muscle is arising from the here. It is from the soft palate. It is inserted into. This is an extrinsic muscle of the tongue. So it extends from the soft palate into the tongue. What does it mean? So it can transmit tumors from soft palate to tongue and vice versa. And there is a anterior tonsillar pillar. Behind anterior tonsillar pillar, you have this tonsillar fossa. Then posterior to that, you have the posterior tonsillar pillar. And the posterior pharyngeal wall at the level of the oropharynx is also part of the oropharynx. And behind the base of tongue. So how will you make out the base of tongue? How will you make out the base of tongue? Base of tongue is posterior to the, this is the circumvallate papilla. And the tongue posterior to the circumvallate papilla is the posterior one third of the tongue. Okay, the tongue posterior to the circumvallate is the posterior base of tongue. And posterior to the base of tongue, then you have a mucosal surface, which is connecting the base of tongue to the epiglottis. That is called the valley. Yeah. Can you mute, please? Thank you. So that is now we will discuss. So this is the
in the room, I found the light is quite dazzling. But present participant.
Please mute yourself.
Dr. Rashi.
Yeah, I am muted here. Okay. Yes. Now coming to the soft palate. Soft palate, you have the different structures. You have, this is a soft palate. This is soft palate, and so this is the oral cavity. So this is if it is anterior to the soft palate, this is a hard palate, and this is the oral cavity. And you draw a line at the junction of the hard palate and soft palate. Then you draw a line which is anterior to the base of tongue. Anterior to the base of tongue. This is a oral tongue. Okay. Now we are discussing the superior and inferior limit of the oropharynx. This is the superior limit of the oropharynx. Inferiorly, it is at the level of the pharyngeal epiglottic fold. This is the base of tongue. And you have the vallecula here. This is the lingual surface of the epiglottis. Okay, the soft palate has three parts. One is the anterior one third, which is underneath the hard palate. It is mainly fibrous. And this forms the palatal aponeurosis, and which is inserted into the undersurface of the hard palate. Then medial part, this is mainly the muscular part, which forms the muscles of the soft palate. There are 5 muscles in soft palate, and there are the 3 muscles are originating from the soft palate: the palatoglossus, the palatopharyngeus, and musculus ovale. And 2 insertion of 2 muscles. That one is the levator vale palatae muscle and the tensor vale palatae muscle. And you have this is the soft palate, and posterior mode is glandular. So if you want to have minor salivary gland tumors which arise from the posterior one third, that's mainly posterior one, that's the uvula. This is the surface, this mainly gland. Okay, the upper border, it is inserted in the posterior margin, the undersurface of the hard palate. Now that's soft palate. And if you look into the tonsil, so this is the palatine tonsil here, the palatine tonsil here. This is the anterior tonsillar pillar, and you have the posterior tonsillar pillar. Posterior tonsillar pillar is nothing but the palatopharyngeus. And the anteriorly, the palatoglossal arch. This is a palatoglossal arch. Posteriorly, the palatoglossal arch, posterior palatoglossal arch, or the palatopharyngeal arch. And the superiorly, it is formed by where the 2 arches meet. This is the superior surface of the, and inferiorly, it is the dorsal surface of the posterior one. And lastly, it is the lateral of the pharynx. And how the soft palate and tonsil is connected. If you know this diagram properly, then you can understand how the tumor spreads in soft palate and tonsil. Okay, this is the palatine aponeurosis. And the muscles arising in the palatal aponeurosis is the palatoglossus, which is an extrinsic muscle of the tongue. So it is supplied by the hypoglossal nerve. The palatopharyngeal muscle, this is arising from the palatal aponeurosis. It is going down all the way to hypopharynx, all the way to the pharynx at the level of the thyroid cartilage. It is inserted into the posterior surface of the the thyroid cartilage. It means so the tumor can spread from soft palate if it involves the palatopharynges to the level of the thyroid cartilage. If you do not know the anatomy, then you will not look by an IL examination. So you may miss. So for that, you may require an MR to know this, but to know if the posterior tonsillar pillar is involved. This is the tonsil. And you have the tongue. So you have the muscles, extrinsic muscle, intrinsic muscles, that I will discuss later. And the insertion of the muscles, you have the levator vale palatal muscle. This is non-medial, and this is insertion. Okay, the origin I have already discussed. Then the tensor vale palatal muscle. This is the lateral muscle. Levator vale palatal muscle is the medial muscle. Okay. So that's how the tumor. So tumors from the soft palate, it can go all the way to base of skull through the levator vale palatal muscle and tensor palatal muscle. And if you look into the staging of carcinoma oropharynx, when the tumor is involving the lateral surface of the nasopharynx, lateral wall of the nasopharynx, then it is considered as T4B because this is how the tumor spread. From soft palate, it goes into the lateral wall of the nasopharynx through the levator vale palatal muscle and tensor vale palatal muscle. Okay, this I have already told you. It arises from the scaphoid fossa of the medial pterygoid plate and also the spine of the sphenoid bone. Then it is inserted into the palatal muscle. This is a levator vale palatal muscle. It arises from the petrous apex bone, the carotid sheath, and also from the medial cartilaginous part of the auditory tumor. So coming to the tonsil, so this is, I need your attention. This is the tonsil. This is a tonsil. You have the anterior tonsillar pillar here. Okay, so this is nothing but the mucosal fold over the palatoglossal muscle. Okay, and so this is nothing. You cannot make out the circumvallate papillary in CT or MR. So you have to locate the anterior tonsillar pillar, nothing but the palatoglossus here. Then you have to say anything anterior to that, it is the oral cavity. Anything posterior to that, that is the oropharynx. So if you have a tumor in the tonsil here, it can spread into the tongue through the palatoglossal muscle. It can spread into the palatopharynges and can go all the way to the lower down to the level of the thyroid. This is, there are two fasciae there. That is, one is the pharyngobasilar fascia here, and you have the buccopharyngeal fascia here. And if you have a tumor there, it can spread, this is a peritonsillar area, it can spread into this muscle. This is nothing but the superior constrictor muscle. And through the superior constrictor muscle, one of the origin is the pterygomandibular raphe. This is the area of pterygomandibular raphe. Pterygomandibular raphe is also a crossroad. From there, this is the buccinator muscle. And this can, the pterygomandibular raphe, interdigitate with the superior constrictor and the buccinator muscle. So if you have a tumor in the tonsil, it can spread in the superior constrictor. And from the superior constrictor, it can go all the way to the base of skull because the superior constrictor is inserted in the pharyngeal tubercle of the occipital bone. So this is one of the reasons why the tonsillar fossa is going into the base of skull. Now, if you have a lesion here, it can also spread to the oral cavity through this is called the buccinator muscle. So from there, it can spread into buccinator muscle and can also invert the matter. And when the tumor pierces the pharyngobasilar buccopharyngeal fascia, it can lead on to the parapharyngeal space here. And from the parapharyngeal space, it can spread into the medial pterygoid muscle. Okay, from the medial pterygoid muscle, there it can go further lateral into the lateral. This is how a tonsillar lesion extending in the medial pterygoid. Lesion extending in the medial pterygoid, it is only T4 disease. Okay, so this is the route of spread of a tonsillar fossa into the parapharyngeal space and also the medial pterygoid. This you need to know. And from there, it can spread. This is a retromolar trigon. So retromolar trigon is nothing but the mucosal fold covering the pterygomandibular raphe. And from there, it can spread into the retromolar trigon. So again, from the tonsil, and vice versa. From the retromolar trigon also, it can extend into tonsil. Then it is very difficult. Okay, so through the pterygomandibular. So I have to discuss two things in detail. One, pterygomandibular raphe, and second is the superior constrictor. So when you take the muscles, when you have the muscles, you have muscles, circular muscle and longitudinal muscles in the oropharynx. So you have the two fascia I have discussed with you, that is pharyngobasilar fascia here. So then you have the muscles. Then the muscles are circular muscles. Circular muscles are nothing but the superior constrictor muscle. You have the longitudinal muscles here. Three longitudinal muscles are there. One is the salpingopharyngeus. Second is the palatopharyngeus. Palatopharyngeus is nothing but what? It is nothing but the posterior tonsillecula. Then other is the stylopharyngeus muscle. All these are the three muscles. Okay. And if you look into all these muscles are supplied by the vagus nerve through but the stylopharyngeus is supplied by the glossopharyngeal nerve, which is the only motor supply of the glossopharyngeal nerve. So you have the superior constrictor here. Superior constrictor is arising from the pterygoid plate, the medial pterygoid plate, from the pterygoid hamulus. So this is the pterygoid hamulus here. Then you have the pterygomandibular raphe, and also it also gives insertion from the mandible. So this is the superior constrictor muscle, and it is inserted posteriorly to the median raphe and also superiorly into the pharyngeal tuber. So this is the superior constrictor muscle. So you have a tumor in the tonsil, it spreads into the superior constrictor, it can lead anterior pterygomandibular raphe, and you have the buccinator interdigitate here. So I will show you that. Yes, so this is a pterygomandibular raphe. It arises from the pterygoid hamulus here, and it is inserted into the posterior end of the mylohyoid line. So there is a mylohyoid line which gives origin to the mylohyoid muscle in the mandible. So I will show that when we discuss the oral cavity. So posterior to the mylohyoid, you have two origins are there. One is insertion, other is origin. The origin of the superior constrictor muscle and this raphe, the pterygomandibular raphe, is inserted here in the posterior to the mylohyoid line, posterior edge of the mylohyoid line. And if the tumor spreads the superior constrictor, it can spread into the buccinator muscle, and it can extend from oral cavity, extend into oral cavity from oropharynx. Then you have the two other constrictors. That one is the medial constrictor, okay, and also the inferior constrictor. So make things very simple. If you are contouring any constrictor at the level of the mandible, it is superior constrictor. If you are contouring any constrictor at the level of the hyoid bone, it is a medial constrictor. If you are contouring any constrictor at the level of the thyroid cartilage or cricoid cartilage, it is an inferior constrictor. Make things very simple. So if you look into this is the medial constrictor. The medial constrictor is arising from the lower 1/3 of the stylohyoid ligament. So this is the styloid process. It is a hyoid bone. There is a ligament connecting the styloid process and the hyoid bone. That is called the stylohyoid ligament. And the medial constrictor arises from the lower 1/3 of the stylohyoid ligament, the superior surface of the hyoid bone. And there are two muscles arising from the superior surface of the greater horn. This is the greater horn of the hyoid bone. This is the body of the hyoid. And one is the medial constrictor, and other is nothing but the hyoglosis muscle. I will show you that when we discuss the oral term. Okay, now you have the superior constrictor muscle here. It arises from the medial pterygoid plate, the pterygomandibular raphe, and also the posterior edge of the mylohyoid line in the mandible. And certain textbooks describe that there is another origin for superior constrictor also. Few fibers arise from the tongue. Okay, but I have not seen in certain textbooks, so I have not included that. So this is the superior constrictor muscle. It is inserted into the pharyngeal tubercle in the base of skull and also inferiorly in the medial. All the medial constrictor, the inferior constrictor are inserted in the medial. Yes. So this we have discussed. The palatopharyngeus muscle is inserted into the posterior surface of the thyroid. Right. So how it is reflected in a CT scan. Okay. It is almost 40 minutes. Okay. So I don't think I will be able to discuss the larynx and hypopharynx today. So I will try to cover the oral cavity if possible. So this is the pterygoid plates here. So this is the nasal cavity. So the pharynx posterior to the nasal cavity is nothing but what? Nasopharynx. So it is very simple. Any pharynx posterior to nasal cavity is nasopharynx. This is hard palate. So the pharynx posterior to the oral cavity is, oral cavity, hard palate is oral cavity. So it is oropharynx. So this is the soft palate. Okay. Soft palate is inserted into the hard palate. Okay. Then posteriorly, this is nothing but the tonsillar fossa. So you have the superior constrictor muscle. Suppose if you want to draw the superior constrictor muscle, you draw like this is the pterygoid hammerus. So this is the lowermost part of the pterygoid, medial pterygoid plates. That's from where the superior constrictor muscle arises. So I said the tumor can spread the superior constrictor further laterally. It can spread to the parapharyngeal space. So this is the parapharyngeal space here on the opposite side. Then you have this is a medial pterygoid muscle, medial pterygoid muscle here. This is arising from the medial surface of the lateral pterygoid plate. So this is a medial pterygoid muscle. This is a medial pterygoid muscle. Here on the opposite, this is nothing but the posterior pharyngeal. You have the carotid sheath here. Okay, what is this? This is the styloid process. Okay, so you can see that there is something which is anterior to styloid process is called the pre-styloid or the parapharyngeal space. Posterior to that, this is nothing but the carotid sheath. Okay, so this is the carotid sheath. You have the internal carotid artery here. This is the internal jugular vein. If you want to look for the retropharyngeal lymph node, you have to look medial to the internal carotid artery. So this is the area where you have to look for the retropharyngeal lymph nodes. Okay, so that is how it is the oropharynx. So coming again, this is a hard palate here, soft palate, and the tonsillar pillar here, tonsillar fossa. Then you have the posterior tonsillar pillar, and the posterior pharyngeal wall. Okay. Okay, this is at the level of the oropharynx. So you have the hard palate here, soft palate. This is a pharyngeal mucosal space. Then you have the parapharyngeal space. This is a parapharyngeal space here, parotid sheath here, and this is the parotid gland here. This is a masseter muscle. This is the mandible. The insertion of the medial pterygoid muscle here. Okay, so this is something which is the buccal space. Okay, that we will discuss when we discuss AROI. Okay, so this is this is nothing but you have two structures here. That is nothing but the duct of the parotid gland, which pierces the buccinator, and it is inserted. It is into the upper second molar. Okay, that's open there. This is the parotid. So how it will look like in MR? MR, it is the hard palate. Hard palate is formed by two bones. One is the horizontal process of the palatine bone, and also the palatine process of the muscle. So this is a hard palate. And behind the hard palate, you have the soft palate. And you have the soft palate here. Then at the level of soft palate, you have discussed few muscles. That is from the soft palate, the inserted into the muscles are the levator vale muscle. So this is the levator vale muscle. Then you have the tensor vale muscle, which is lateral. So you have two muscles there. Then you have the medial pterygoid muscle. It's a medial pterygoid muscle. And this is a mandible. This is a masseter, which will look like. Okay, these are all fat, the buccal part of fat here. And you have to, you have the posterior pharyngeal wall, longest capitis muscle here, longest colli muscle here. You have the parapharyngeal space. This is the parapharyngeal space. Yes, you have the superior constrictor here. It is down. This is superior constrictor. This is you have the levator vale muscle and the tensor. Then coming to, So coming to the level, at the level of the tonsillar fossa, so this is little down. So you have this tongue here, you have the base of tongue. Okay. Then base of tongue is also part of the oropharynx. Okay. So you have the anterior tonsillar. So this is the palatobulous arch. So if you have anything anterior to this palatobulous arch, you have the arch here, palatobulous arch, it is the oral. Okay. So this is the palatobulous. This is the tonsillar bed. You have the posterior tonsillar pillar, or nothing but the palatopharyngeal muscle here. And you have the muscle here. This is the posterior belly of the digastric. Posterior belly of the digastric forms the lateral and the anterior boundary of the level to lymph node. So this is the internal carotid artery. You have the jugular vein here. Yes. So how it will look like in a coronal? Like it's very simple, but you need to understand. So this is nothing. This is a soft bed. This is the tonsillar. Okay. Lateral to the tonsillar bed. What you have? You have the constrictor muscle. So this is the tonsil. lateral to that is the superior constrictor muscle. So in MRI, this is grayish. So this is, the air will be black, okay, jet black, but this is grayish. This is superior constrictor muscle. Lateral to superior constrictor muscle, you have the parapharyngeal space. This is the parapharyngeal space, okay, and this is continuing down. Then you have another muscle called, this is nothing but the Styloglossus muscle. Styloglossus muscle is also one of the muscles of the extrinsic muscles of the tongue. Okay, so styloglossus here. You have the medial pterygoid muscle. This is the medial pterygoid. This is the masseter. This is the lateral pterygoid muscle here. And you have the epiglottis here.
Dr. Cessal, can you speak loudly? There's a request from audience.
Yes. I'm sorry. Okay. So if you have a tumor there in the tonsil, then you have the lesion can spread into the retromolar trigone. This is through the pterygomandibular raphe. It can spread posteriorly to the carotid sheath here. It can spread into the parapharyngeal space. Then you can spread into the medial pterygoid muscle here, and also this I have already discussed. So this we have seen everything we have discussed. Okay. So coming to the base of tongue. So how will you distinguish the anterior two-third of the tongue and the base of tongue? You need to understand this, the anterior two-third of the tongue muscles, mainly the transverse muscle. Okay, sorry, this is transverse and this is longitudinal. So this will be something like transverse and this is more longitudinal. I will show you when in MR. Okay, so if you have a tumor there in the base of tongue, it can spread to the opposite side, and the base of tongue tumors is prone, is notorious for crossing the midline, producing a bilateral lymphadenopathy. So if you have any patient with a chronic smoker or alcoholic present with a bilateral level 2 hard fixed mood, the most important thing you have to do is that you have to palpate the posterior non. Okay, so this area is prone for a bilateral level 2 lymphadenopathy. And from there, it can spread into the anterior two-third of the tongue. It can spread into the parapharyngeal space. It can spread into the carotid sheath, posterior pharyngeal wall, etc. Yes, base of tongue. So this is how it will look like in the base of tongue. Sometimes this is the base of tongue. Okay, so this area I will discuss later, because when I discuss the oral tongue, okay, because it is little complex, okay, I will discuss that later. That is base of tongue. Coming to the vallecula. So vallecula, this is a mucosal space between the tongue and the epiglottis. Okay, so this is a space there, and it is connected by medially by the median glossoepiglottic fold, and laterally by the lateral glossoepiglottic fold. And the lateral glossoepiglottic fold is the anatomical terminology, but radiologically it is called the pharyngoepiglottic fold because it is connecting the pharynx. This is the lowermost part of the oropharynx, connecting the pharynx, pharyngoepiglottic fold. This is pharynx, it is connected to the epiglottis, that is called lateral glossoepiglottic fold, is also called the pharyngoepiglottic fold. Okay, so this is the median glossoepiglottic fold here. You have the vallecula on the either side. Okay, this is how you look like in a CT scan. This is a median glossoepiglottic fold, and this is the vallecula. This is the lateral pharyngoepiglottic fold, or lateral glossoepiglottic fold, or pharyngoepiglottic. And this is epiglottis. This is epiglottis, which is connecting the pharynx to the epiglottis. That is called the pharyngoepiglottic. This is the caudal limit of the oropharynx. Okay, then epiglottis is continuing, is the array epiglottic fold, and posteriorly it is the piriform sinus that we will discuss when we discuss the larynx. Okay, and then you have the so this is a sagittal view. The sagittal view, you can see that this is the base of skull. So this is the sphenoid sinus. This is the soft palate. You have the base of the tongue. You have the vallecula here. This is the lingual surface of epiglottis. So any tumor in the oropharynx which is extending into the lingual surface of the epiglottis, then that is called it becomes a teeth disease. And there is a ligament which is connecting the epiglottis and the hyoid bone. This is called the hyoepiglottic ligament, which we cannot see in CT or MR. But when that ligament is pierced, the tumor in the oropharynx can enter into the pre-epiglottic space. This can enter into the pre-epiglottic space. Okay, then this is another route of spread of the base of skull. Then from there, the base of tongue can enter into the floor. Okay, so this is the tongue. Okay, so you have the intrinsic muscles and extrinsic muscles. The intrinsic muscles are the superior longitudinal, the inferior longitudinal, the vertical, and the transverse. This forms the intrinsic muscle. The extrinsic muscles are the main bulk is formed by geniohyoid muscle. Geniohyoid muscle, this is a mandible which arises from the genital. There is a tubercle there. There is a superior and inferior tubercle there. Genital, that is it arises from the tubercle, genuine tubercle in the mandible, which is inserted into the tongue, and few fibers are also inserted into the hyoid bone. So this is the geniohyoid muscle. That other muscle is the hyoglosis muscle, and these are the two muscles which we can clearly make out in MRI. So you will not be able to see the styloglosis muscle always. So palatoglosis I have told you earlier. So the hyoglosis muscle, I have told you earlier that it arises from the hyoid bone. It is inserted into the tongue, in the lateral surface of the tongue. Okay, so this is the extrinsic muscles of the tongue, which is nothing but this is the palatoglosis, which arises from the palatine aponeurosis inserted into the tongue. And the second muscle is the styloglosis muscle, and this arises from the styloid process inserted into the tongue. That is called styloglosis muscle. And the main bulk of the extrinsic muscle is formed by the geniohyoid, which arises from the genuine tubercle here in the mandible. It's inserted into the tongue. And the fourth muscle is the hyoglosis muscle, which is lateral, and hyoglosis muscle, you can see the hyoglosis muscle is arising from the greater horn of the hyoid bone inserted into the tongue. Okay, we have discussed another muscle which is arising from the superior surface of the hyoid, that is a medial constrictor muscle. Okay. So how you will look in the CT scan or MRI? CT scan, it is difficult. Okay, CT scan is is difficult. So we will take an MR. Okay, so this is nothing but the geniohyoid muscle. This is geniohyoid muscle. Okay, this is geniohyoid muscle. Okay, then this is the lingual septum. Why you need to know lingual septum? Lingual septum contains fat, because when a tumor in the tongue or a lesion in the base of tongue involving the anterior tooth of the tongue, if this lesion is crossing, this lingual septum will not be centered. Okay, this is a lingual septum. Then you have the muscle. This is the curvilinear muscle. This is the hyoglosis muscle. This is hyoglosis muscle. And you have the mylohyoid muscle. This is nothing but the mylohyoid muscle. Mylohyoid muscle is a sling muscle which arises from the mylohyoid line of the mandible, which is inserted into the hyoid. Okay, so this is the mylohyoid muscle. Then you have this is called nothing but the sublingual space. This is the sublingual space. Sublingual space contains the sublingual gland, the duct of the submandibular gland, the lingual nerve, the lingual artery. Then this all come here in the sublingual space. Okay, then posterior to you have the submandibular gland. This is the submandibular gland. And you cannot see this in a CT. It's very difficult to differentiate the extrinsic muscles in a CT scan. Now coming to the floor of mouth. The floor of mouth is formed by three muscles, mainly three muscles. One is the mylohyoid. So the mylohyoid is this is a mylohyoid muscle. So it's a sling muscle. It's a muscle arising from the mylohyoid ridge in the mandible, and then it is inserted into the hyoid bone. So then you have the geniohyoid. Geniohyoid muscle is arising from I said that the superior mental spine or superior genital tubercle is for the origin of the geniohyoid muscle. Then the inferior genuine tubercle gives origin to the geniohyoid muscle. This is a geniohyoid muscle. It is inserted, and it is again also a pyoid muscle, forms the floor of mouth. And other muscle is the anterior belly of the digastrium. This is the anterior belly of the digastrium. That I will discuss when I discuss the 1A here. So you know that there is this is the sublingual space. Sublingual space contains the lingual nerve. This is the submandibular duct or the Wathin's duct. Then you have the sublingual gland and also the lingual nerve, lingual artery, and lingual vein. And you need to understand this area. This is this is nothing but the mandibular foramen. From its two structures are there. That is, one is the inferior alveolar nerve and inferior alveolar arch. Because when you have a sublingual gland, there is a adenoid cystic carcinoma, you can have a perineural spread through the lingual nerve. The same way, if any tumor which is infiltrating the mandible and there is a widening of the mandibular foramen, then this can have a perineural spread along the inferior alveolar nerve. And both are the divisions of the posterior division of the mandibular nerve. So it can trace up to, so then it traces up to the foramen ovale. So you have to trace that, then you need to look whether there is a perineural spread. Okay. And what is sublingual space? What is sublingual space? It is, you need to identify two muscles here. The muscles are, this is the sublingual space. This is the mylohyoid. Okay. From mandible to hyoid. This is a mylohyoid. Then you have the geniohyoid muscle. So which lies between. So this is nothing but the mylohyoid muscle. Then you have the hyoglosis muscle. You need to understand two muscles. One is the mylohyoid muscle and this is the hyoglosis muscle. And the space between these two muscles is nothing but the sublingual space. Okay. And this I have shown you in axial cut, but I will show you in the coronal view also. And so this contains the sublingual and the Warthin's duct. Then you have the sublingual nerve, the sublingual artery, and the lingual nerve. The structures in the sublingual space. That is why you need to understand. Okay, I will show you in a coronal MR. So this is nothing but the geniohyoid muscle. Then just close that, then you have the geniohyoid. This is called lingual septum. And this surgically, if you want to know what is the root of the neck, there is difference between root of the neck and base of the tongue. The root of the tongue and the base of tongue. The root of tongue is formed by the septum and genioglossus and geniohyoid complex. So this is nothing but the root of the tongue. Then you have this is the geniohyoid. So this is the genioglossus, geniohyoid muscle. Then there is a sling muscle. This is a mylohyoid. Below that, you have two muscles. That is nothing but the anterior biliary diastole. Okay, this is very important when you need to understand that when you need to understand the one-eighth lymph space. Okay, so I will discuss few of the muscles which are inserted into the mandible because this is very important. Then, if you know this, because you can understand where the muscles are originating, inserted, etc. So this is nothing but this is the condylar process of the mandible. This is the mandibular notch. Any tumor which is coming to this level is called the supranotch disease, and it is more or less considered as an inoperable disease. This is the temporalis muscle insertion because it is inserted in the coronoid process in the superior aspect and also the medial surface. Now you have I told you that medial pterygoid muscle is inserted into the medial surface of the ramus of the mandible at the level of the ankle. Okay, so this is the medial pterygoid muscle. Then you have the mylohyoid muscle. This is called nothing but the mylohyoid ridge. I told you that there are two muscles, one muscle and there is one insertion of one tendon posterior to the mylohyoid ridge. This is the origin of the superior constructor muscle and also the insertion of the pterygomandibular raphe. Okay, then the mylohyoid muscle, which is dividing the sublingual space with the submandibular space. Okay, so this is the sublingual space, this is the submandibular space, or the submandibular gland is here, the submandibular gland, or you have so this is a mind. So when you need to contour the level 1B, then you need to look for the mylohyoid muscle at the level. That's the level you look for the 1B level. So you have the insertion of two muscles. I told you that is the tubercles are there. The superior one is the origin for the genioglossus muscle. The inferior one is for the geniohyoid. Okay. If you understand this much, then you will be able to understand the various muscles here. Now coming to the buccal mucosa, you have the buccal mucosa there. Then lateral to you have the buccinator muscle. So you have the mucosa here. Then you have the buccal. There is a muscle there, that is the buccinator muscle here. Lateral to buccinator muscle, you have the buccal pad of fat. So, okay, this you have the buccal pad of fat. Lateral to that, you have the skin. So you have a tumor there. then you can spread into the buccinator muscle, then into the buccal pad of fat, then into this. It is very common problem you come across in your clinic. And then you can go down. It can spread into the gum. It can spread into the mandible. Personally, it can spread into the retromolar trigone. There is a comment that retromolar trigone is also part of the oral cavity. I agree that this is part of the oral cavity. So this is a retromolar trigone. So this is a area where you can come. Then once the retromolar trigone is involved, then you can go into the superior constrictor through the pterygomandibular. Okay. Yes. Then so this is the buccal mucosa. Then how you will see in the, so this is the puffed cheek. Okay, method maneuver to see we make out the buccal mucosa clearly. Okay, so this is nothing but there is, you can see the normal mucosa there. Then you have the muscle there, buccinator muscle. This is the lower GB sulcus here, the upper GB sulcus here, and you have the buccal pad of fat. Then you have the skin. Okay, so you can see that this is a hard palate. Then you have this is a hard palate, and this is a retromolar trigone. You can see this is an area where retromolar trigone. Then from there, it can spread into the medial pterygoid muscle, a constrictor, through the pterygoid. This is lip. This is the upper lip. This is the lower lip, the labial mucosa, the lower lip, the labial mucosa, and this is the mucosa surface along the upper lip. Again, this is another picture. So this is a hard palate. You have to look. This is the area. This is a coronal view. You have to look at the lesion in the, if you have a lesion in the hard palate. If you have a lesion in the hard palate, if it is in the upper alveolus or the hard palate, then if it is going into the maxilla, then it becomes T4. If it is a maxilla going into the oral cavity, it is only a T2. So that's important. And you need to understand the hard palate because apart from the direct spread to the oral cavity, into the maxilla, it can also have a perineural spread through the greater palatine nerve and also the lesser palatine nerve. The greater palatine nerves supply the hard palate, the lesser palatine nerves supply the soft palate. And this enters into the, this leaves the oral cavity from the greater, through the greater palatine foramen here. So this is the greater palatine foramen. Then you have the lesser palatine foramen. The greater palatine foramen enters into the greater palatine canal. From there, it can go into the pterygopalatine fossa. So this I discussed. When I discussed the pterygopalatine fossa, that I will discuss the pterygopalatine canal when I discuss the oral cavity. So this is the pterygopalatine canal. This is how the pterygopalatine fossa communicates with the oral cavity through the greater palatine foramen. Through the greater, from the greater palatine foramen, it gains access to the greater palatine canal. And from superiorly, it goes into the pterygopalatine fossa. And from the pterygopalatine fossa, it can gain access to the brain through the foramen rotundum. Okay, so this is the another view. This sagittal view of the you can see greater palatine foramen, and also canal. Then it enters into the pterygopalatine fossa. Okay, so retromolar trigone. Retromolar trigone is again a crow's row. From there, it's also part of the oral cavity. It can gain access to the medial pterygoid muscle, into the tonsil, can enter into the tongue, then bone, and into the buccal mucosa anteriorly. And it can also gain access to the, if you have a lesion there, it can also have a perineural spread from there, okay, through the areas which we have discussed. So coming to the muscles of the neck in the anterior view. So this is the this is nothing but the anterior belly of the digastric. Okay, this is nothing but the anterior belly of the digastric. So anterior belly of the digastric, between the two belly of the anterior belly of the digastric to the belly, you have the 1A lymph node. This is nothing but the 1A. The 1A lymph node extends from the mandible to the hyoid between the two belly of the digastric. Then you have the anterior belly of the digastric, you have the posterior belly of the digastric. And between the anterior belly, posterior belly of the digastric, and the mandible, this is the submandibular, the 1B lymph node region. And then you have the hyoid bone here. You have the hyoid bone, and the inferior, the caudal edge of the hyoid bone forms the caudal edge of the 1A, 1B. And so this is the caudal edge of the 1A and 1B. is, and also level 2 is at the level of the caudal edge of the hyoid bone. So all the caudal edge of the 1A, 1B and level 2 is formed by the caudal edge of the hyoid bone. This is very important, which we have seen, all the muscles which you have seen in the hyoid bone. Okay, so this is a 1A region between the two belly of the, and this is the antebelly of the digastric. It's a medial aspect, and this is the lateral edge of the antebelly of the digastric, which forms the medial boundary of the boundary of the 1B lymph node. It extends into the symphysis membrane. Laterally, it is the skin and the platysma. This is the platysma muscle. Then posteriorly, it is the posterior edge of the sublingual. Extends from the level of the mylohyoid muscle. Superiorly, it is coming down to the level of the caudal edge of the hyoid bone or the caudal edge of the submandibular gland, which is inferior. Okay, now we have the level 2 lymph node posterior to the 1B lymph node, that is the posterior edge of the posterior edge of the submandibular. Okay, this I will discuss later. Level 2 lymph node I will discuss later. Okay, now coming to the level 2 lymph node. So the level 2 lymph node, the superiorly, the anterior edge is formed by the anterior edge of the posterior belly of the digastric. So this is the posterior belly of the digastric. The anterior edge is formed by the posterior belly of the digastric. And also the lateral boundary is formed by different structures. One is the posterior belly, the medial edge of the posterior belly of the digastric. So this is the posterior belly of the digastric, the medial edge. This forms the lateral boundary of the level 2 lymph node along the internal carotid artery and the jugular vein. Then you have the parotid gland, also forms a boundary. And in certain cuts, it forms the platysma, also from the lateral. And the main boundary of the lateral boundary is formed by the medial edge of the sternum. So the structures are: 1, parotid gland, the posterior belly of the digastric, platysma, and the medial edge of the sternocleidomastoid. So this is the sternocleidomastoid. Then you have the medial edge of the level 2, level 3, and level 3. Level 2, level 3, and level 4, the medial edge is formed by the scalenus muscle. So this is the scalenus muscle. Okay, anterior, medial, and posterior scalenus muscles are there. And posterior to level 2, level 5, is posterior to the, so this is the level 2 level. And superiorly, it extends from the C1 vertebra to the caudal edge of the caudal edge of the hyoid bone. Okay, so this is that's all about the oral cavity, level 1A, 1B, and level 2.
Is there any questions, or everyone has understood everything?
I think Dr. Cessal has explained so much in details. There's
That's what,
no question.
That's what I was telling my son, that this kind of anatomy was told in, in our time. See, our teachers, they were like this thorough. I don't know what is the status now in medical colleges. So you're really good. I really enjoyed it.
Definitely.
Thank you.
Revision for us also. And it was fantastic lecture.
Yeah.
And definitely we'll have another session, remaining part of this. And soon we'll disclose this.
It's a mystery then.
Yeah, there's one question, Dr.
Yeah, superior, I will take up that. Okay, superior and inferior, and that's a very good question. Okay, just below the base of skull, then you have the infratemporal fossa superiorly, and go down to all the levels. So we have a zygoma, from zygoma to the level of the mandible. So actually there is a difference between, there is a controversy regarding the inferior boundary of the infratemporal fossa, but it will go up to the middle of the mandible, to the level of the ramus of the mandible.
I think there's no more question. Definitely it was very fantastic lecture. I should congratulate you, Dr. Cessal.
Thank you, madam.
Dr. Anu, thank you so much for moderating the session. And soon we will send, please continue, Dr. Anu.
I just said thank you, Dr. Surbi, to give me, for giving me opportunity, and obviously to listen to this particular session. It's really nice.
Okay. Thank you, Dr. Anu. Thank you, Dr. Cessal. And thank you all the participants for patience listening. Thank you, everyone.
Thank
And
you very
thank you,
much.
RPG Life Sciences, for giving this platform for us. Thank you.